Now, after this introduction, we try to continue with our program. You have the title, Regional Anatomy of the Lower Limb. The lower limb is separated from the trunk by inguinal groove. So just we could say that lower limb, just basic information, lower limb separated from the trunk, of course, from the belly, from the abdomen, from trunk by this is easy, by the line, we call it inguinal groove. In fact, groove means ligament anteriorly, and we call it intergluteal line medially, and iliac crest. No, in fact, posterolaterally. This is sufficient. We start as usually with the dorsal region, not dorsal, normally ventral, but dorsal must be as an extra reason explained as the first one. We are looking now at some diagrams. This is the short review of the regions. We start with the gluteal. The reason is that gluteal contains so many important structures that descend, and this is the only one on the dorsal side. Then follows the posterior, but then follows the anterior area. Here you see the inguinal ligament or inguinal groove with the anterior region, which is called regio femoris anterior femoral region, which is divided also or subdivided into the trigone, anterior trigone, femoral trigone, and also fossa iliopectinea, as we will see. Then in the central position lies the regio genus, the genu. Then follows the anterior crural region and dorsum pedis. On the dorsal side, again, the gluteal region, then posterior femoral region. Here is the fossa popliteal region belonging to the regio genus, and also crural region, posterior one. And then there are two areas which have specific names. We call them retromalleolar regions because malleoli, and they are situated on the medial and lateral side. That's why we call it lateral malleolar region and medial malleolar region. And finally, there is the planta pedis. So dorsum pedis, planta pedis belong to the foot. No, and then the first one would be this specific because it contains the biggest nerve in our body. This is the sciatic nerve. Here we are looking at the gluteal region from the iliac crest to the sulcus gluteus inferior, we call it distally. The basic information concerning surface on the very strong fascia, suprafacial space in subcutis. This sends some cutaneous nerves. We call it nervi cluneum superior, the medial or mediate, and then the inferior. Then some small vessels that perforate the subcutis. That means with a thicker or thinner layer of the fat. The deeper layer shows again these cluneal nerves. Then we see gluteus maximus. After cutting the gluteus maximus, we can see the deeper layer, deeper structures, which are more complicated. Again, you see the gluteus maximus cut. Then medius lies below and minimus, but here in the key position, the piriformis muscle, which divides the whole space, which is called superior or greater opening. We call it greater sciatic foramen. We see on the same orientation of the diagram, we see that larger, bigger, greater sciatic foramen. This is the lesser sciatic foramen. And then the greater sciatic foramen is divided by the horizontally passing piriformis muscle into the suprapiriform foramen, infrapiriform, piriform, we can say. So foramen suprapiriform foramen contains the neurovascular bundle supplying the muscles. This is nerve and artery and vein. or veins. The same is here, infrapiriform, foramen infrapiriforme, but also the neurovascular bundle that supplies the floor of the pelvis, the nervus pudendus and internal pudendal artery and vein, plus posterior cutaneous nerve, femoral, and also the biggest one, as we said, biggest nerve in our body, the sciatic nerve, nervus sciaticus. So these are the first things. Pay some attention also to these two diagrams. Better is that one. We are looking at the dorsal view. We see the area divided into 4 quadrants with oblique bluish hatching. We see the area which is called safe area, safe for the intramuscular injection, frequently used, because the other ones, especially that one, contains the nerves, and especially the sciatic nerve, which stands in the median plane, covered by the flexors. And there is a very small area. You see, I'm showing again that area where the nerve is practically not covered by strong fascia passing obliquely, and then is covered by the flexors on the dorsal side. Again, the superior gluteal artery and veins, and inferior, then the position of the piriformis is in that line. Well, so quickly, the region, the gluteal region, the first one, which is specific. So starting with maybe numbering number 1, and could be framed by blue. Why not? And then the title would be the gluteal region, gluteal region. Good. Gluteal region, the boundaries, first of all, quickly, the boundaries is gluteal, maybe here, boundaries. We try to do the best because there are so many information. I would like to do the maximum today in the lecture. Maybe 1 page could be sent again as a handout. By the way, I'm sending you the papers. No response. I sent something also yesterday, day before, and I don't have any confirmation that you get it. Maybe that the email addresses are not working absolutely because one was returned. So please do try to react and send me. I would like to have some feedback. Gluteal region, yes, boundaries concerning the gluteal sulcus, we said, gluteal sulcus, the inferior one, then crista iliaca, that's it, crista iliaca, and the median plane iliaca, sufficient. No, and starting the layers, maybe that layers could be explained in the left column, and here I try, maybe it could be even bigger, yes, and also this is not necessary. Excellent. So we see I would try to draw the half only. What do you think? Vertical line. Yes. Iliac crest, lip. Then position of the head, of the greater trochanter, definitely of the femur. First of all, sketching like that. Yes, it could be even smaller. No. Okay, and then we need the ligamentum sacrotuberale, sacrotuberous ligament. Okay, this will be like that, not with many details. What we need is the piriformis, musculus piriformis, then sciatic foramen, and also suprapiriform foramen. Okay, so drawing immediately the arteries with the veins supplying all this region. Here is the sciatic foramen, and also the nerve is sufficient. Fine. Then piriformis in light red. Passing over the space, sacrotuberous ligament in light green, descending. That part is called tuber ischiadicum. ischial tuberosity. Then here would be also the quadratus femoris, just to show that that the nerve passes over. Then here we have the neurovascular running medially. That means the artery, vein, and nerve, pudendal. Then also in infrapyriform foramen descends the superficial nerve, cutaneous, and also don't forget that here descends the sciatic nerve. Fine. The foramen here, the smaller, deeper is the quadratus femoris. There are also the other muscles. I'm drawing just a few lines. The reason is that we call all of them, the pelvic trochanteric muscles. No, it could be like that, and maybe just add some yellow color to show this will be definitely green, because this is the capsule and trochanter, etc., sufficient. That's good. So for better illustration, here we have the iliac crest. Better handwriting. Iliac crest, crista iliaca. Then here all the structures, we call them superior gluteal vessels, because these are artery and vein, plus plus nerve, right? Plus nervus gluteus superior. Fine. The same will be here, because I have to complete also the drawing, because also here are the branches of the inferior gluteal vessels, like that. So we can simply add here, we place the inferior gluteal vessels plus nerve. Then that one is the sciatic nerve, L4 to S3. With these big nerves, we have to remember also, learn also the segmentation. And here is the posterior cutaneous femoral. I mean that these abbreviations are well known. Femoral nerve, because we use these abbreviations also in the topography, review of topography of upper extremity. No, here we say the superior or greater sciatic foramen. Why not? You can just put the arrow greater sciatic foramen. Here would be the inferior or lesser sciatic foramen, but I will put comments on the left side. No, and the ligament is sacrotuberous ligament, and this is the tuberosity. This is more or less logical. And that muscle is quadratus femoris. Small muscle, and belonging together with that one to group of pelvic trochanteric, descending from the pelvis to greater trochanter, to different positions on the posterior side. That means that they are also the outer rotators. So this is the dorsal view. So as usually, we have to add also the specification dorsal view of the region, framed traditionally by green. Fine. So I mean that this is more than clear, more than sufficient. Please note that the pudendal then run. I'm just drawing the arrows. They run artery, vein, and nerve. They run medially to the floor, into the pudendal canal, So maybe that is not bad to add thicker arrow. And here just add some dots with the note that the pudendal structures, we said, because I have to add that these structures are pudendal internal pudendal vessels nerve, and they run into pudendal canal. Pudendal canal. We will speak about that later. The pudendal canal lies on the medial side, or no, lateral medially oriented in the floor of the pelvis. But we will put one more note. Good. So then in gluteal region, the layers. First of all, simply layers in the gluteal region. Number one is the skin, thick skin, definitely. Then number two is the subcutis. Subcutis contains thick fat layer, depending on the individual. So fat or fatty layer, and also the cluneum plus cluneum nerves. I will draw also one simple thing to add also one more drawing, because there is no place. One more diagram to show, and I will draw one instead two drawing the iliac crest, the lateral position like that, median plane, sulcus gluteal, sulcus position of the gluteus maximus. Gluteus maximus, maybe it's not bad to add these two lines. Okay, iliac crest, fine. And then what else? Two lines, why not yellowish? So and so, two lines, dividing the whole space into 4 quadrants. And also that zone using light green, that one is called safe area, clinically very important safe area for the intramuscular, that could be relatively deep intermuscular injections. Safe because there is nothing specific, but here we see the course and position. It runs more laterally, but here's the position, again repeating, using thicker yellow color. We see the sciatic nerve. So again, sciatic nerve runs in the inferior medial quadrant, while in the lateral and upper and lower, nothing specific, just vessels, etc. So this is not that complicated, and maybe that is not bad idea to add also some nerves, the cluneum. So I will add some lines only, these ones, and inferiorly these ones. So these thick lines indicate the cluneum or cluneal nerves, and they're called superior. Then the second are the medial gluteal met. I will sufficient medial, and these ones are inferior. This is sufficient. Of course, here would be also the cutaneous posterior femoral nerve sufficient. Okay, so I mean that this is quite clear that we see not only the position, it could be even more medial, but doesn't matter. Better is to say that it lies in this position, but it's good. So we fully understand the position of the nerve. It runs mediolaterally, proximo-distally, following in the subcutis, sufficient. Number three is the fascia femoris, so simply femoral fascia. As in the deltoid region, this is the same femoral fascia attached to fibrous septa, because the fibrous attached to fibrous septa in the gluteus maximus of the gluteus maximus muscle sufficient. Then there is also the trochanteric bursa. The bursa lies here. It's not a bad idea to draw also the trochanteric bursa, which is situated on the dorso inferior surface may be that. We can say also trochanteric bursa, pouch-like space, and instead to put any labeling is that one trochanteric bursa. No good. So this is quite clear. And then follows the layer of the muscles. We call them gluteal muscles, and then pelvitrochanteric. I'm not drawing an extra diagram, but pelvic trochanteric are the muscles which run mediolaterally. You can look into the atlas piriformis, quadratus femoris, gemelli, superior, inferior, and the tendons of the internal obturator. So the names will not be mentioned at the moment. Then, of course, we would say that follow now in the same layer, of course, below the gluteal muscles, are the sciatic foramina. It should be mentioned as a specific topic because sciatic foramina are important passages, sciatic foramina, for the structures. Foramina, we have seen the greater and lesser will be that one. So sciatic foramina, starting with first one, maybe A could be the greater sciatic. We have seen also the diagram in the book, sciatic foramen, divided by piriformis muscle, and this greater sciatic foramen contains the should be explicitly mentioned as the superior. It contains superior, no, better, we could say suprapiriform foramen divided by the musculus piriformis into the first would be the suprapiriform foramen, foramen, which contains suprapiriform foramen, which contains the superior gluteal vessels plus nerve. That's it. And then on the next page, inferior, sorry, it must be completed. So we see the greater sciatic foramen divided by musculus piriformis into the suprapiriform, and on the following page by the infrapiriform foramen, which will follow. And this will be that one which contains much more structures than the previous one. So looking now on the next page, and here we see the arrow infrapiriform foramen, which simply contains the inferior gluteal vessels plus nerve, but also a pudendal nerve plus internal pudendal artery plus vein. And then we said, using that black, these two structures run and descend, as we said. You remember, we said with some dots that they go to the pudendal canal. So it goes to they descend into the pudendal canal in the pelvis, or Alcock's canal. These names are used usually by the clinicians, so then we use these eponyms also for us as the second names, just to know. And then it supplies also the floor of the pelvis. So this is that one, and also inferior gluteal vessels, definitely, plus a sciatic nerve. We know that sciatic nerve is the biggest nerve in our body, longest nerve, strongest nerve, and also posterior femoral cutaneous nerve. So these are all the structures that pass through the greater sciatic foramen, and B is the lesser sciatic. This is the inferior one. I will show you again the diagram. Lesser sciatic foramen. Here we have both foramina again. Here, look, please. Here is the greater sciatic and lesser sciatic. Both. Here is the supra-infra piriform foramen, and the lesser sciatic we used just AB. So this lesser sciatic foramen contains only the tendon, because the nerves pass through the lesser sciatic foramen into the Alcock's canal, like that. Better maybe to draw both arrows to the lesser sciatic and back into the pudendal canal, and also the tendon, also the tendon of obturator internus muscle. Good. No, safe area, we said. Sufficient, absolutely correct. We are approaching now to the second region. This is the femoral region. Femoral ear is more the larger, not more complicated, but contains more structures. So we could say femoral region, regio femoris, femoral region. This femoral region contains or consists of two subregions, anterior and posterior region. Maybe that would not be bad if we try to draw the compartments, but first of all, boundaries, some words to the boundaries. Yes. So concerning the boundaries, what we could say is inguinal ligament, inguinal groove, and also groove, definitely, because it's a superficial. Then using the same arrow, and we are 3 fingers above the patella. So cranially, superiorly, we are looking at patella. So this will be at this level. When we look at patella, now, based on the general agreement, 3 fingers above patella. Area into two compartments. So maybe that better would be to start with a simple sketch, just sketch showing the transverse section, transverse or cross section. And this transverse section shows the skin subcutis, which could be thick. So again, depending on the individual. Then nearly in the center, we have the femur, and to femur are attached to septa, laterally also iliotibial tract. We call it fascia lata, or fascia femoris, or femoral fascia. On the lateral side is the tract thickened portion, iliotibial tract, correct. Femur, yellowish, why not? And also the veins, maybe just one will be sufficient, which is on the medial side, is the greater saphenous vein. Important. Vena saphena magna. Why not to use the Latin word vena saphena? Sometimes we may mix vena saphena magna, but greater saphenous vein will be repeated in many other sections, diagrams. No, and then the intermuscular septa, that one is called lateral intermuscular septum. Septum, like lamina, divides the whole space into two compartments, A and P, because A would be the anterior compartments. I'm not repeating the whole name, osteophacial compartment. And these compartments is A, anterior. Anterior, in fact, contains the quadriceps femoris, simply extensors at the knee joint, and these are flexors. There is some lamina, like another septum, separating two groups of the muscles. P is divided into the area where we can see the sciatic nerve, then artery, thicker artery, we call it arteria profunda femoris, and anteriorly there is also connective tissue forming, not directly the septum, but the space for three important structures: artery, vein. I don't have place. Okay, I will place the vein here, and the nerve also. The nerve is femoral nerve and saphenous. There are more nerves, definitely, and here is also the nerve inside. Everything belongs to the femoral nerve. Fine. The dorsal compartment, so anterior, this is the simply quadriceps, mainly quadriceps, because there is also sartorius femoris, quadriceps. B is the posterior, and posterior compartment contains two subunits, one with the obturator nerve and obturator artery and veins. This is much smaller. This compartment contains, I will put it below, obturator nerve plus artery plus vein, and this is the area containing adductors or adductors of the thigh, so that means at the hip joint, and this here is the sciatic nerve plus arteria, or better deep, profunda, because you can read it in the atlas, is both names, deep, profound, deep, femoral artery plus veins, arteria profunda femoris. Good. So this is the orientation, and then we could start with the anterior femoral, because you see it's divided into the anterior posterior compartments, starting with the first one, A. So the title would be 2A, anterior femoral compartment. Good. Compartment, or also region, definitely, because we are speaking about the regions. Okay, region, good. Concerning the anterior compartment, we see now the structures found in the anterior compartment, but before we will start with the compartment, we have to say that that into the anterior compartment descend the structures from the lacunae. So first of all, we will name the structures, and then we have to go back to the lacunae because there are two openings permitting the passage of structures descending from the abdominal cavity into the lower extremity. Anterior femoral compartment contains thick skin in layers. Number two, subcutis, which contains the branches of femoral nerve. These are the branches we said. Then there's a sensory, definitely sensory nerves, because these ones are the motor. Then a nerve which descends from the abdominal surface is the genitofemoralis, also sensory, and also sensory part of the obturator. In subcutis, nervus obturatorius, everything is sensory, definitely, because we are in the cutis or in the subcutis. No, fine. Number three is the not yet. We have to add also the veins, because the veins in the subcutis are visible, and one is the most important. The veins are thick and open into the veins, open into the vena saphena magna, the great saphenous vein. Now we use the English version, great saphenous vein. And there are many veins. Maybe that it would not be bad to see, but I will draw a special diagram. Opening great saphenous vein, then vena femoropopletea, descending proximo-distally, and sometimes also vena saphena accessoria. No, I say, but would be again better to put accessory saphenous vein. We will need diagram. Number three is the fascia, femoral fascia. We already used the name lata, also fascia lata femoris, and also two septa plus, two septa dividing the whole space, we said, into the anterior posterior compartment. No, and then number four, the muscles in anterior compartment is the quadriceps femoris, and also the sartorius. So this is like a second group or second category, correct? And then also number five are the principal vessels, femoral artery plus vein. They run together, and they finally descend into the adductor canal. We will draw also adductor canal. That's it. So we see all the structures, and then what we need is to draw the great saphenous vein on the anterior, or in the anterior compartment, on the following diagram. There's definitely no place. Before we will draw it, first of all, the saphenous vein, yes, I will do. And before we will do it, we have to maybe just draw one simple sketch of the structures that pass through the abdominal cavity. So I would say that nerves plus vessels descend to femoral region, through, of course, from the abdominal cavity through the lacunae. So we have to start now with another diagram showing two lacunae. Lacuna is a passage, and without any details, we don't need any extra drawing. Starting with the anterior superior iliac spine, so inguinal ligament, and then also the space like that, and so on, so on. Here you see the pubic symphysis, just quickly coloring the bone here. This is sufficient in light green, the inguinal ligament, that's it. And we see two lacunae, maybe 1, 2, or using Roman numerals. And then there are two lacunae. I'm using the colors for muscles. Here is the muscle iliopsoas muscle, plus two black dots indicating the nerves, femoral and lateral cutaneous. And in the second lacuna, there are two vessels, always in the lateral position, the artery, always on the medial position, the vein. And using also like there is the lymph node. So there are two lacunae, number 1 and number 2. The number 1, sorry, it must be like that. Number 1 is the lacuna. This is muscular lacuna, muscular, and number 2 is the vascular lacuna, number 2. And this is the muscular. There is a small septum which contains the lateral femoral cutaneous nerve, sensory. Then muscle is called iliopsoas muscle, and that thick dot is the femoral nerve. So we see lacuna musculorum, muscular lacuna, and vascular contains the femoral, always on the laterals, femoral artery plus vein, and the most medial structure is the lymph node, inguinal, of course, inguinal. It's better writing. Inguinal lymph node, and is well known under the name cloquet inguinal lymph node, cloquet. We call it also cloquet, sometimes also cloquet. Okay, cloquet. Good. And then the thing is that through this lacunae descend the structures into the femoral region. Quite good. Then what we have to mention also that anteriorly we said that I'm just sketching quickly. We see the anterior side, anterior view, and we said that there is a fascia lata femoris, fascia lata covering the whole thigh, fascia lata like that. Fascia femoris or femoral fascia. So, but in the most proximal part, there is the opening into this fascia, forming and hiatus. We call it hiatus saphenous, hiatus saphenous hiatus, using green because it's the hiatus saphenous, hiatus is opening. And here in this hiatus we see just part of the femoral artery, but femoral vein, using that color, vein, and also into the vein opens great saphenous vein, right? This great saphenous, it receives also the pudendal veins, 1, 2. Here would be logical the inguinal ligament. Then from the anterior inferior part of the abdomen wall is the superficial epigastric, and also in the same vein open the circumflex. I will label them. So usually all these three vessels open into the great saphenous vein. Of course, they could be also the other accessory veins, etc., etc. It runs together. So I can say that it's the great saphenous vein, and these two are the femoral artery plus vein, always artery on the lateral side. And then the tributaries is number 1, number 2, and number 3. We say tributaries to, or tributaries of the great saphenous vein is number 1. Number 1 is the external pudendal veins. The number 2 is the circumflex, but epigastric, superficial epigastric vein, superficial epigastric from epigastrium, superficial epigastric vein, and number 3 is the circumflex ilium, circumflex ilium vein. Sufficient. So we see also the anterior view, which is not bad to know. No, and concerning the femoral region, again better, femoral region contains in the most proximal part also the small depression. We call it iliopectineal fossa, contains proximally part of the or better is to say proximally or continues with proximally with the fossa iliopectina. I will prefer to use the international name, version, fossa which opens into the anterior region. So this is just to know that femoral region is continuous with the, or contains proximally fossa iliopectina, which opens into lacunae, and lacunae are continuous with the opening here. And then anterior region can be divided into the this is inguinal ligament again, into the trigone. Proximally there is a trigone like that. We call it a femoral trigone. We will not speak about the structures inside because it's absolutely the same. Just if you will read and look into the books, don't forget they call it femoral trigone. Which is bounded by sartorius, mass laterally, this is that one. Then proximally is the ligament, inguinal ligament, and medially is the adductor longus. So when we describe this anterior femoral region, so the centrally located part of the femoral region is the femoral trigone. So maybe that is not bad to color by blue the whole femoral region. This is the blue femoral region, and inside is the trigone, right? So this is the femoral trigone inside. But of course, the structures are absolutely the same. So we have discussed the anterior view, lacunes, the trigone, just technically, and then as the note to the following passage of the femoral artery and vein, they descend into the adductor canal. So we would say that femoral artery plus femoral and femoral vein, repeating but in blue, femoral vein, they descend into the thick arrow, descend from the anterior position in the femoral region. They descend into the popliteal fossa, into popliteal fossa, descend into the popliteal fossa through the canal. We call it adductor canal, through the, and again red, adductor canal, also called Hunter's canal. Again, the surgeons, they prefer this name. And this Hunter's canal, I would draw, maybe it's not a bad idea to draw the canal we are looking from above, the Hunter's canal. So this is the anterior, we are looking from anterior view. The Hunter's canal is triangular structure, bounded by vastus medialis. So we are on the medial side now, vastus medialis muscle. Then laterally dorsally is the no, both of them, maybe that we could change the arrow, vastus medialis and adductor magnus muscle from this side, and ventrally anteriorly is the vastoadductor membrane, vastoadductor membrane, membrana vastoadductoria. And note please that always laterally descends the artery, always on the medial side is the vein, and finally dorsally, dorsolaterally descends through the canal, also the nerve, which finally leaves and is called the saphenous nerve. Saphenous nerve, which descends to crus and foot. And pass, why not Latin? It's also improving your Latin terminology or international medical terminology. Good. Look how the structures descend. First of all, the artery runs obliquely. The artery. This is the passage of artery. Then we see the continuation. The vein crosses dorsally posteriorly the artery, like in our drawing, like that. We see the vein here, and of course the artery sends the muscular branches through the canal, and we see also the course of the saphenous vein. So it goes to through crus. That then we are now at the level of popliteal fossa, popliteal fossa. It seems to be complicated, but I'm repeating it. Again, we are describing the anterior femoral compartment. First of all, the structures pass from descend from the abdominal cavity through the canals or lacunae. They are situated in the fossa iliopectina, as we said, and then they descend to the anterofemoral region, which could be described also as centrally located, the trigone, but in general, everything belongs to the anterior region of the femur. In the anterior region, we see the fascia lata, fascia femoris, which has the opening for the hiatus saphenous hiatus for the biggest structure found in the subcutis, the vena saphena magna, the great saphenous vein which contains or receives the tributaries, as we said. No, and then concerning the bigger structures in the area, the femoral vein and femoral artery, they descend into the popliteal fossa, through the Hunter's canal. We see the boundary, we see the course, and we see how the structure changed their position from lateral to medial and from medial to lateral posteriorly, and also the accompanying nerve, saphenous nerve, belonging to the femoral nerve. We can this is the branch of the femoral nerve, and they appear in the posterior side, in the fossa poplita. So this was the anterior region, anterior femoral region. Then follows the posterior femoral region, which is more easy to see. And as usually, we try to look at some diagrams because it's not bad to see the anterior region. So look at the anterior region. Here we see the whole view, proximally inguinal groove, then anterior superior iliac spine, then hiatus saphenous, you see this relatively large opening, femoral artery, femoral vein, then these three tributaries, or four, opening into the great saphenous vein. It could be also the accessory vein. Accessory vein usually could be the vein that could have also many variants. The fact is that we have mentioned, I have to add also to the drawing one thing. There are also many lymph nodes. We see the diagram of lymph nodes which have many interconnections as you see them. We divide them into the superficial lymph nodes and deep ones. Deep follow the femoral vessels, superficial ones follow the position of the great saphenous vein, and then you see the collectors on the anterior side. So maybe that to the previous drawing, so please do add some oval fields to say that all these are the superficial inguinal lymph nodes. This is important, and we have to draw them. We have to color them by no, we can leave them. Oh, no, we have to color them by green because this is better to see. They are arranged into some groups. The clinicians divide them also into medial lateral group and super inferior, but in fact there are superficial, all of them, and deep ones are situated alongside the arteries. So then here would be the deep ones. This is absolutely sufficient. So this was the first region, anterior femoral, and this was 2A. 2B shows the posterior femoral region. We remember that posterior femoral region would be, we said, not so complicated, definitely. Again, some diagrams. First of all, this was what we mentioned concerning the passage of the larger vessels from the trigone. You see, this is the trigone, and from the trigone, the artery and vein plus saphenous nerve descend behind the lamina vastoadductoria, and then they appear in the posterior surface of the fossa poplita. Then you see many variants of the course of the artery. Of course, in the deep vessels are the branches of the femoral artery. This is the vena arteria profunda femoris. Maybe that we could say, if we look at the region, this was anterior femoral region. Yes. So please do add one branch, important branch. This is the anterior femoral region compartment, femoral artery and vein into the adductor canal is correct, and then also the femoral artery dividing into many branches, then not descending to adductor canal, but sending many branches, and we would name them This is the arteria profunda femoris, important branch that supplies the dorsal side. Then muscular branches, many, and profunda femoris, the whole name, sense also circumflex arteries. This is sufficient. So it's important to mention this profunda femoris because this is the second biggest artery in the area. That's it. So fine. We are now in the regio femoris posterior femoral compartment. This would not be so complicated because we can just name the structures in different layers. Yes, layers. Number one, thick skin on the dorsum. Then distally thinner. Number two, subcutis, what we see on dorsal side, usually on the border, could be femoropoplitea, could be vena femoropoplitea. It could be also situated more on the on the central medial and posterior side, femoropoplitea. Definitely, it also opens into the it descends to the popliteal region. Then posterior femoral cutaneous nerve branches, and also branches of could be also of obturator nerve, but mainly medially. Then number three is the fascia femoris, femoral fascia, femoris, not femoralis, femoris. Then follows number four, muscular layer, or simply muscles, and nerves. Of course, they are flexors, so this is easy to remember that is a sciatic nerve. We can put also sciatic nerve, we said. No? And then sciatic nerve with the branches already mentioned. And then number five, this is that deep femoral artery, we would say perforating arteries. We could say the rami, the branches perforantes, the perforating arteries from the profunda femoris artery. That's why I already mentioned that the rami perforantes are three, and they supply the whole block of the muscles of the flexors that are situated in the deepest layer of the region. Sufficient, done. No, and then the following area is the knee regions, because these are the regiones genus, the knee region, knee as a knee joint. So knee regions are simply called regiogenus. So this would be number three, and we call it knee regions, or officially is called regiogenus. Why not use both versions of terminology? Knee regions. No good. Concerning the knee region, is bounded proximally, but again boundaries. Our arrow showing the proximal. We said that this is the line passing three fingers above, 3 fingers above patella, Yes, if we see the patella, no, fine, patella basis, so 3 fingers here, and in the, no, not here, must be more distal. Here's the patella. Great, patella. Yes, 3 fingers must be 3 fingers above. And then caudally, inferiorly, distally is the line passing distally by tibial tuberosity. Okay, we could say tibial tuberosity. Full name, tibial tuberosity, sufficient. So this is the extent of the area. No good. Concerning the anterior, again, we divide it into anterior, posterior, knee region. So looking first of all on the anterior, 3A is the anterior knee region, anterior knee region. And this anterior knee region could be not drawn completely. Again, you have better diagrams, just sketching the position of the patella, then the attachment to patella, which is the rectus femoris quadriceps, and distally there is the ligamentum patellae, patellar ligament, and here you see the muscles forming the vastus lateralis, vastus medialis, and rectus femoris. So simply quadriceps femoris. Good, patella without any text, and patella. And then we see the medially descending nerve, which sends many branches in this region. This is called saphenous nerve. Good. And then also medially descending vein with some tributaries. This is called great saphenous vein. Great saphenous vein. That's it. So anterior is easy. So knee region anteriorly, skin is relatively thick. You can palpate it on your knee area. Here could be on some bursae. We would say subcutis, and usually it could be also subcutaneous plus it could be subcutaneous bursa. There bursae are many around the knee joint. We would name them. It contains subcutis contains a great saphenous vein. We said great saphenous vein, just abbreviations. Then tributaries, saphenous nerve. We said. Saphenous nerve, and then follows number 3, fascia. We call it crural fascia, and beneath the fascia we see the bursae, position number 4, bursae, plural, because there are more. According to the position, we name them subfascial, because they are situated beneath the fascia. Subfascial, prepatellar, right? Then also infrapatellar, infrapatellar, and suprapatellar. Bursa could be connected. We could say communicates, usually communicates with the knee joint family cavity, with the joint cavity. So there is the whole family of the bursae, and the bursae eliminate or reduce the friction during the movements, the whole process, and the only one suprapatellar could communicate directly to patella. Quadriceps femoris contains patella, so number 5 is patella. We know that patella is a sesamoid bone and is attached, you see, by the ligament to the tuberosity. That's it. I'm sure that it doesn't need more. No, but more complicated is 3A. Okay, so that means must be 3B. Here is the place 3B, and we call it posterior knee region, regio genus posterior knee region, and this contains the following, and I have to add one simple drawing sketch. This is thin skin. Yes, we know that is skin is thin, easily movable, so it is easily movable, must be thin. Then fatty layer, subcutaneous simply in the fatty layer contains in fact small saphenous vein that opens, saphenous vein, vena saphena parva, plus tributaries, which penetrates the fascia, entering the popliteal vein. So it opens into the enters the popliteal vein. That's it, popliteal vein. Also, there is medial sural. No, we call it either medial sural cutaneous nerve. No good. So next page. Then we follow to the description. We go to number 3. Number 3 is the fascia. We call it simply thick fascia because it's really thick fascia. Now, and then follows number 4 is that fossa. So deep structures are found in the fossa popltea. Maybe that we can just write fossa poplitea. No, and here is the best place for drawing, for just sketch because we will see maybe first of all would be diagrams. Fossa poplitea. We have this fossa poplitea in this picture, looking at the boundaries. I will draw better down boundaries. There are flexors proximally, semitendinous, semimembranous, semitendinous. Then laterally is the biceps femoris attached to the head of fibula, and distally are 2 heads of the gastrocnemius, lateral gastrocnemius, medial gastrocnemius. At the center, we see the nervus tibial nerve, which is the direct continuation of the sciatic. Laterally descends the fibular or peroneal nerve, also behind the head of fibula. And then we see in the opposite order when we compare it with the position of the structures found in the lacunae. So here is the vein, this is the artery. So, and then the other diagrams show the variability of the position of the floor. Floor is the popliteal muscle, and then the artery which lies either on it, some branches go behind, etc. Again, many varieties. So not necessary to draw a whole diagram, just sketch. Again, this is much more effective drawing the fossa boundaries, proximal, distal, as you see, proximal, distal, then the tendons, as you see here, it would be sufficient. So boundaries could be thicker. Here on the lateral side is biceps femoris, muscle, laterally, okay, laterally, just for better orientation. Then here we see the lateral head of gastrocnemius muscle. This is the medial head, lateral medial, sufficient. And then on this side we have two muscles. This is a membranous and at semitendinous muscles. Fine. And then at the center, because there's no necessity to color them, in the most medial position descends the artery. Note please that this artery gives of many branches to the knee joint dorsally, so they run dorsoventrally. It must be here also the vein following the same tributaries as the artery. This is the vein. Artery lies just deeper. And on the lateral side, you see the tibial nerve, tibialis descending, tibial nerve, and then peripherally descends then the fibular. So concerning the structures is easy, vein and artery medially. So femoral, not femoral now, this is femoral definitely, but here we call it popliteal, popliteal artery plus vein, or vein plus artery. This one is the nerve, tibialis, tibial nerve, and that one is the fibular, descending fibular or peroneal nerve. That's it. So I mean that the simple sketch helps or is better for orientation in the fossa. And then also maybe light green shows the boundary. So this is the popliteal fossa. I'm sure that this is good. Contents also not the private contents, because we see it in the in this diagram. What should be mentioned also here? Ascends the vein. The vein is called small saphenous vein, which ascends, small saphenous vein ascends from the dorsal side of the crus. Then follow the next area, next region. We call it regio cruris. This would be number 4. Regio cruris, or crural region, also leg region. All these terms are used. Regio cruris, crural, etc., etc. No good. Extends, so boundaries, or extends from tibial tuberosity. So from, and we see again the tibial tuberosity distally to to the line of ankles. So malleoli or ankles. So in this extent is subdivided into the anterior posterior part, which is logical. So maybe that again will have one simple sketch showing the position. First of all, in very close proximity to the surface is the fascia, then deeper, because then dorsally could be thicker subcutis, or even much thicker subcutis, but medioventrally is very thin. We can palpate, in fact, the tibia in the whole extent, ventro-anteriorly. So I'm drawing thick, bigger, larger tibia. Dorsally, laterally lies the fibula. I'm exaggerating the difference because fibula is really here in the mid part, thinner than tibia with the bone marrow cavity. If we have place here first separating line is the interosseous membrane, yes, interosseous membrane, and tibia, definitely no need to add more than T, and fibula not necessary, but from fibula run two septa, forming the third compartment. So again, we have compartments, which are 3 in number: anterior, posterior, and lateral. Lateral means fibular. So anterior, posterior, lateral. Anterior is that one which contains extensors. Here are in fact the flexors, and here are the fibular muscles. So anterior, posterior, and lateral. Good. So we see the compartments. Don't forget to add here the fascia cruris, crural fascia. Note please the position of the tibia in close proximity to the skin. And then also here on this side we have the great saphenous vein. Great saphenous vein, not necessary to write the whole name. No, and then there are extensors like that. Here we have different situation in the dorsal side. There is one subseptum or subunit, which is divided by the deep fascia, because this is the interosseous membrane, and this is the deep fascia or deep portion of the fascia, and it subdivides the whole space into the deep, where are deep muscles plus the tibial, posterior tibial artery is the anterior tibial artery. Here will be the peroneal fibular artery, and the artery always descends together with ascending veins in all the cases. We remember from the description of the upper limb the rule that in the periphery the arteries contain always two veins because of pulsation of the blood. Here is the there are two muscles. The deep ones is called soleus. Of course, you will look in the atlases. And here we have this, the gastrocnemiae. So maybe that here we can put just gastrocnemius. It's not bad to repeat. Gastrocnemius. Dorsally, posteriorly, small saphenous vein. This is the great saphenous vein, which descends which ascends with the sural nerve. So here we have, you see the small saphenous vein plus sural nerve. Good. Concerning the neurovascular bundles found in all three compartments, so anteriorly must be deep fibular nerve. Here is the superficial fibular nerve, and here is the biggest nerve, the nervus tibialis. So I'm just putting the lines. The first one here is the we call it anterior tibial artery plus veins plus deep fibular nerve. Laterally is the fibular artery plus two small veins plus superficial fibular nerve, superficial fibular nerve. So in the anterior crural region, we have the anterior tibial vessels plus deep fibular nerve, and laterally is the superficial fine. And here we see the posterior tibial artery plus veins plus tibial nerve. I'm sure that this simple sketch shows better than long description the situation in each area, and then concerning the contents we can reduce it. Starting with quickly the interosseous membrane and two septa. That one is anterior septum, anterior intermuscular septum, and logically that one will be posterior septum. There's no place and also not necessary to name them. And the septa divide the whole space into two compartments in one lateral. So we could say that 4A would be anterior crural region, anterior crural region, which contains, and now we will just name the layers, skin, which is relatively thick, then relatively thin subcutis but thin anteriorly, ventrally, but thicker dorsal and posterior, but dorsal is a different thing. Just we would say that here in subcutis we see the tributaries and great saphenous vein sufficient. Then important thing is I would frame the saphenous vein and mention that they are using another color. There are many transfacial or yeah, better to say transfacial venous interconnections, or we could say interconnections. So in these connections, and the crew is definitely interconnections with the deep veins. No, deep veins are tibial, anterior tibial, dorsally would be posterior tibial, also with small saphenous, with the deep veins. These interconnections are valveless. They don't contain any valves, and they are clinically very important because these veins are called perforators. We call them perforating veins or perforators, and they were described by surgeons in the distal third, in distal or distally maybe, or distal third lies the group of the Coquet's perforators. There are Coquet's perforators, and in proximally are variable. These are relatively constant, variable, but the following are called Boyd's perforators, for what we have the perforators. The perforators permit or allow the intercommunication between the superficial and deep veins. So they play important role in hemodynamic balance between the deep and superficial system. But also don't worry. Important thing is also not only this role, but they are used also, or they are places where there are so many defects in the vascular system. So it's important for surgery, for surgeon or phlebologist. That means the experts dealing with the diseases of the veins. No. And what else? Lateral. So that means there is also laterally must be superficial fibular nerve. Subcutis also laterally there is the superficial fibular fibular nerve. So most important is the group of the perforators. This is number 3. Number 2. Number 3 is the fascia cruris with septa, nothing else. Distally it forms the extensor retinaculum, superior extensor retinaculum. We will see it in the diagrams. Retinaculum. We know the retinacula stabilize the position of the tendons. No, this is number 3. Number 4 are and then we have deep vessels, so we could anteriorly are the muscles, long muscles, plus the vessels, we said, because these vessels are here, plus nerve. Of course, this is the deep nervus fibularis, nervus fibularis profundus, deep fibular nerve, what we mentioned. No, and then we have good. Then follows the posterior crural region, but before that we have to say just one sentence to the lateral osteophyseal compartment, which is not bad to know. Then lateral, just without any number, but for lateral we used L reddish. So then please, we must do the same. Lateral osteophyseal compartment sufficient. So then lateral osteophyseal compartment contains, as we said, just simply the fibular muscles. We said longus, fibularis longus, important also for the plantar supporting also the plantar arches, both of them, transverse and longitudinal. Brevis also not that much, is shorter. Then this osteophyseal compartment contains also common fibular nerve, because in this region it divides into the superficial and deep. So deep goes ventrally, superficial laterally, and what else? Then the fibular nerve. I haven't mentioned fibular nerve, and fibular muscles plus tendinous vaginae, tendinous vaginae, tendinous tendinae vaginae. So, and also we have to mention the retinacula to retinacula, fibular retinacula, superior, inferior. I will show you immediately the diagram. So we are looking now at the lateral osteophyseal space. Do we have something? No, we have. Yes. Together with the malleolar regions, maybe that this would be the best one. We are looking at two sides. This is the lateral superficial. We see the nerve. This is the sural, I will mention also, and the lesser saphenous vein, which collects from this side superiorly, proximally. And then we see the peroneal nerves or fibular nerves. That one is long. You see it crosses the superficial one. Superficial is short. It goes medially and is attached to the contralateral side to the first metatarsus and the medial cuneiform bone. Both of them are covered by the vaginae synoviales. tendinous vaginae, and this one is the the more superficial. This is the one which is attached to the tuberosis of the metatarsus number 5. These are regions. This will be the this is the posterior. No, posterior will follow. I will show you again together with the posterior. So this is just the lateral osteofacial compartment, sufficient. And then we have to mention 4B, which is the posterior crural region, also calf region, also we call it calf region. And the posterior region, we see just some structures. Maybe that it's not necessary to mention everything, just some words. Number 1 is relatively thick skin. Then number 2, subcutis. In subcutis, we see the small saphenous vein, then we call it the medial sural cutaneous nerve, which joins, maybe that we can say medial sural cutaneous joins. I put the whole sentence, joins the sural or lateral communicating branch to form sural nerve. So if we draw the cross section, we see always the sural nerve, but more proximally these two communicating branches. Sufficient. Number 3 is the sural fascia. That's it. And then number 4 are the muscles plus deep vessels and nerves, which we have drawn in the diagram. And here we have mentioned also deep lamina of this fascia, which separates the deep muscles from the superficial ones. So, and nerves. So how is it with the sural fascia? Nerves, we said sural nerve. And then muscles, muscles are arranged into 2 groups. You see, I'm leaving the right column for one diagram. There is the superficial group of the muscles, which is represented by triceps surae muscle, and the second one is the deep group, separated by the lamina, and deep group consists of the long muscles, that means posterior tibial, then flexor hallucis longus, and flexor digitorum longus. Of course, there is also the popliteus on the floor, popliteus superficial plantaris doesn't play any role, and the superficial group triceps surae, this is absolutely sufficient. Then the arteries and veins will be seen in the diagram. I'm just sketching the situation because it's important to know that if we see the muscle, the soleus, we said this is the deeper one, because soleus, this is soleus, I'm cutting it, and then this is the continuation of the soleus, like that, and superficially are 2 gastrocnemiae. See, two gastrocnemiae. I try to color them. Gastrocnemius, another gastrocnemius medial lateral, and soleus with oblique hatching, like that. So soleus, that one is also soleus. So please, both are a soleus muscle, and these two are gastrocnemiae, gastrocnemiae muscles. Good. And then it must be colored by the same color, light color, like that one, and this is the same, soleus, fine. And soleus forms proximally the arch, arcus of soleus, arcus musculi solei. We see it, so we call it arch. We call it tendinous arch, tendinous arch of soleus, And this is important to know that this arch of soleus surrounds descending vessels. Of course, there are also the muscular branches. We are leaving the fossa popltea. So this is the artery, then vein. You remember, in correct position. This is more lateral, and finally, the most lateral is the tibial nerve, right? Of course, here they are also both. This is the fibular nerve, and that one is the tibial. So when we are on the side, we are on the lateral. Just for better orientation, we are on the lateral, that was the medial side. So this is the soleus again. Here, with branches are they are in fact still popliteal artery plus vein, and artery, and this is the nerve, correct. So this is the arcus of soleus, and here is the popliteal muscle, no need to draw. And here you see the continuation of the course. Here we have the vein, then changing the position would be the artery, like that, artery with branches definitely, and then the nerve. You see, this is interesting to see how they run. But all these are not popliteal, they are the posterior tibial, right? So this is not bad to know the whole situation. So concerning the contents in this posterior crural compartment, we need one more structure, which is the vein. We'll perforate it. This is the small saphenous vein, and here would be the sural nerve on the lateral side. So vein and nerve, and this is all to the contents, because one drawing will be more effective for description. Deep group and superficial group, easy. So sural, we see sural nerve and small saphenous vein. I'm sure that this is sufficient for us. Fine. And now we are approaching to the retromalleolar regions. Again, the diagram. Here we are looking from backside, the medial retromalleolar region, lateral retromalleolar region. On the lateral, you see again the sural and the small saphenous vein with many interconnections with the great saphenous vein. This is logical. And here we see the malleolar regions. First of all, the medial, superficial layer, deep layer. So on this, we will not draw such complicated drawings. Definitely, we don't have such or that much time. This is the great saphenous vein, and many interconnections also with the opposite side. The branches of the saphenous nerve, deeper, same, but behind the medial malleolus, from which runs also the flexor retinaculum. We see in the specific position the tendons. This is my book, so I can color the tendons. This is the tibialis posterior, flexor digitorum longus, then vein, artery, vein, nerve, flexor hallucis longus, dorsally posterior is tendon achillis, Achilles tendon attachment to the with attachment to the tuberosity. This is what we saphenous, small saphenous vein, then sural nerve, and then we see both retinacula. This is the superior fibular, inferior fibular. These are the retinacula on the dorsum pedis, superior, inferior, and we see the tendons with tendinous coverings. So the number anterior crural, posterior crural, anterior, posterior, this was 4B. So then number 5 are the retromalleolar regions, RGG, extend from ankles to the Achilles tendon. No, from just at please from the ankles, malleoli, from the malleoli. Why not to use international name malleoli? To Achilles tendon, right? Tendo Achilles or tendo calcaneus. We can say just some words because this we have seen diagrams and we will not draw diagrams so complicated. You have atlases, retromalleolar region starting with 5A. The medial, more complicated, medial retromalleolar region. This medial retromalleolar region contains the following structures. Again, maybe that it could be bluish, also bluish, underlined by red. This is up to you. The material region, it contains, as usually, the relatively thick skin. Number 2 is subcutis. In subcutis, what we see in the subcutis definitely would be the fascia with the flexor retinaculum. Subcutis, just superficial nerves plus veins, the tributaries. This is sufficient. Number 3, fascia forming the flexor retinaculum. The flexor retinaculum contains or consists of 2 layers, superficial and deep, but for our description now, retinaculum is not necessary. It covers the structures. We will draw them. In subcutis also plus bursa subcutanea, bursa subcutanea, cutanea. Yes, fascia, flexor retinaculum. Under the retinaculum run the structures. We will use the numbers, and then in sketch just the without names. Under the retinaculum run the following structures. Run A, B, C, D. So that means posterior tibial muscle, then flexor digitorum, flexor digitorum longus, and then posterior vein plus artery plus vein, because they run on both sides. Then posterior, then it must be tibial nerve, and E must be flexor hallucis longus, the most posterior. Flexor hallucis. So we have all the structures which will run under, or which run under the flexor retinaculum, run the following structures. we see them on the simple sketch on the following diagram. Controlling the time is still good. Just look at the medial side, and it's like that, sketching the tibia, the tendons. One thing, yes, moment, tibia like that, bursa. Then we need more space, and it would be like that, the outlines. So very good. This is the bursa. Here would be the tibia, just looking at the tibia. And also we can, if you have place, we can add also the veins that form the arches on the surface with the tributaries, etc. And also the saphenous nerve, which ends at the level of the medial side of the first metatarsus. So we have the outlines. Don't forget to draw also the flexor retinaculum, which color? Dark green, like here. This will tendocalcaneus on the dorsal side, and calcaneus for better orientation. This is the bursa. We said subcutanea, bursa subcutanea, and then look at the course of the muscles. This will be tibialis posterior. This is just a tendon. Then a part of the muscular portion plus tendon of the second muscle, which is the flexor digitorum. It runs more distally into the planta. There's a second one. Then follows vein artery, vein artery, both of them run into the plantar region. Again, vein, because there are two veins, they are interconnected in some places like that. And then finally, it must be another muscle, which is the tendon of it's also running obliquely, and the last one is the flexor hallucis. There is a cleft, and in the cleft descend the structures, I mean the neurovascular bundle. So for that muscle, I would use light green. There is a belly of the flexor digitorum, plus tendon, different green, flexor digitorum, and finally the strong tendon of this tibialis posterior. Here we need separate lines, so we see all the structures. They pass distally, and then of course here would be tendo Achilles or Achilles tendon, Achilles tendon. Fine. Here what we see are and then we used I have to look at the previous paper, tibialis posterior, small a, then flexor digitorum longus, B, then vein artery is the C. There are three structures, and then must be tibial nerve. Sorry, must be tibial nerve. I didn't mention tibial nerve. This was my mistake. Tibial nerve, and this must run like that. So here the nerve is D, and the most dorsal is E, flexor hallucis. So the most ventral is the posterior tibial muscle, then follows flexor digitorum longus, then vein, artery, vein, but nerve, and then finally the flexor hallucis longus. Achilles tendon separates or runs distance separately. So all these structures, as you see, they pass with the exception of the A, so they descend into the planta region. So I would say into planta. Here we see again, sorry, must be great saphenous nerve. We said many times saphenous nerve plus great saphenous vein medially. No, medial malleolus bursa, everything was quite clear. And then it would be B, the lateral, more easy, lateral retromalleolar region, lateral retromalleolar region. This lateral retromalleolar region, again we see skin, which is relatively thin. Skin number 2 is the subcutis. So subcutis contains, we said, and we have seen diagrams, small saphenous vein plus sural nerve. Then fascia follows fascia dorsalis pedis. Then follows the group, I would say, tendons of fibular muscles with synovial sheath or tendinous sheath, as we said, sheath plural, under retinacula, no, and number 5 there also no, nothing else, because we will not name the lateral collateral ligament, no reason. So this is the lateral region, not complicated, no. And then finally we are finalizing the lecture today. This would be number 6, and this is called dorsum. We could say either 6A, 6B, maybe regions of the foot, and if we divide it into A, this is dorsum pedis, and then B is planta pedis, dorsum pedis. So regions of the foot. Finalizing it, the dorsum diagrams, pictures. Here we have dorsum. I mean that we can just sketch, not draw complicated diagrams, absolutely no need. When we look at the dorsum superficial layer, we see all the structures. First of all, in the key position, surgically important is the great saphenous vein on the medial side, but you see it forms very irregularly. The arches, we call it rete venosum dorsale pedis. Rete, that means network of the veins on the dorsum of the foot. Then definitely important are the nerves. They are divided into the practically cutaneous, dorsal, lateral, intermediate, and medial nerves. They come from the previously described nerves. If we have here again the drawing, you remember that anteriorly must be the deep fibular, but on the side runs the superficial fibular, so that the fibular nerves, and they form the cutaneous branches. There is exception in the first space between the first and second metatarsus. They are the artery and veins, definitely, and nerve. This one is definitely the profound deep fibular nerve that pass in the cleft, which could be narrower, longer, shorter. Again, many variants. This one is relatively long. The fascia covers or forms the retinacula. This is the superior extensor retinaculum, inferior as X type, inferior extensor retinaculum. Beneath the retinaculum descend the tendons, long tendons of the extensor digitorum longus, extensor hallucis longus. Sorry, these are short. This is the long extensor hallucis. Together with the short ones, we see the short tendons of the extensor digitorum brevis, extensor hallucis brevis, and here you see the tendon of the, maybe again it could be a little bit colored, the tendon of the tibialis anterior. So we see reticula, we see the arteries. The artery together with the veins is called the arteria dorsalis pedis, the dorsal artery of the dorsum pedis. The artery descends from the anterior tibial. It gives off the muscular branches and also the branches that run to both sides. Arcuate is the distal one. They are malleolar branches, and they are also the branches to the passing into the plantar side. They are perforating arteries. Here, the many varieties of the artery. It could be, I would say that this is the most frequent type when we see just the continuation of the anterior tibial dorsalis pedis into the first space between two metatarsal bones, and here is an arch. We call it arteria arcuata, arcuate artery, from which then descend the metatarsal dorsal arteries dividing into the digits. So this is the dorsum pedis. Quickly, dorsum pedis is the area which has the layers, I mean movable skin, we would say, because we can palpate also the structures. We can palpate the tendons. We can palpate or see the network of the veins, so that we can see the dorsal venous network. In subcutis, we have the dorsal. We said dorsal venous network rete venosum. Not bad to add also the second name, rete venosum dorsalis pedis, sufficient. And then the nerves, I would say sensory nerves that descend, they run under the venous network, under the veins. They usually run under the veins, and they are called medial, intermediate, plus laterally also sural. But sural nerve doesn't belong to the fibular nerve, because this is is a combination of the tibial and peroneal fibular. No. Number 3 is the fascia. The fascia is relatively thin, but fascia also is thickened into the inferior extensor retinaculum. It was quite clear in the diagram. So fascia and retinaculum, subcutis fascia. Then follows the group, I would say, tendons of long extensors, sufficient extensors. Then are the plus and arteria dorsalis pedis, because this runs between them, plus veins, arteria dorsalis pedis plus veins. And then follows the group of the short extensors. I would say accompanied by the deep fibular nerve. We said fibular nerve, and final number 5 are the tendon, no, simply short extensors, because the short extensors are not only tendons but also the bodies. Short extensors, we will not name, this is not necessary, because we know that this must be extensor extensor hallucis, extensor digitorum. This is very easy. So I mean that this could be all. The question is if there is the reason to draw or to sketch these tendons, or better just looking at the section. Maybe that dorsum would be IM for one section instead of drawing. Just when we look at this extensor, so this is the inferior extensor, just sketch, right? Just sketching, because there is a place, and not to use that place would be bad. So here we have the extensor, inferior extensor retinaculum. On the extensor descend the great saphenous vein with the saphenous nerve. We will not name them, this we will not label them. And then there are also some superficial nerves. Here must be the cutaneous dorsalis medialis. This is the lateral and medial cutaneous nerve. These are here. Medial intermediate, so this is the medial and intermediate is here. Now, intermediate and medial. Medial intermediate. So because sural is on the dorsolateral side. But I would just mention that under this retinaculum descends here the artery, which runs like that, runs medially, forming some branches to sides, and also forming the arch, the arcuate artery. Then it divides into the dorsal branches. This is the longest one. So just to know the situation, of course, there are tendons of the extensors, plus here's the tibialis anterior. We can add here the tibialis anterior muscle. Retinacula could be colored now by green, and I will label them. This is simply the inferior retinaculum, logically extensor retinaculum. Here is the arteria dorsalis pedis, with the veins, of course, with the veins. Pedis, this is that one. This one is arcuate, arteria arcuata, arcuate artery, logically with the veins. And these arteries are called in fact metatarsal dorsal arteries. No, sufficient. And the very last drawing for today, for this lecture, we have still some minutes. The best would be the cross section, which is very nice. Sorry for a little bit, it's a little bit more complicated, but fantastic. I would say cross section through the, I would say at the level of metatarsals. The last drawing promising metatarsals. I hope that you still stay and you are still sufficiently patient. because now follows definitely very nice drawing. I would prefer to draw bigger drawing. We need more details. Then using green drawing the fascia, you see very thin space dorsal, much thicker on the plantar side, because we have the section of the dorsum and then just some names, some words to the plantar. Very good. So we see here the plantar aponeurosis, thickened portion, very important. Plantar aponeurosis for walking, for stability of the foot, for the plantar arches support. Plantar aponeurosis. This is the fascia plantar, or simply the fascia of the foot. No, fascia pedis. Good, fascia pedis, sufficient. No, and then we need the position of the metatarsal bones. So starting with the first one, number 1, then there is also superficial fascia. No, it would be better to draw that small space here, because this fascia would be connected with the tendons like that. So then the second one, third one, fourth, and fifth, like in our drawing, metatarsal bones. Good, good. This is sufficient. Then the spaces between them, and then space of the little, so we call it lateral plantar space, medial plantar space, and then the spaces for interosseous muscles. And for the interosseous, we usually use 2 colors to show that they are dorsal abductors, stronger, and on the plantar side 3 adductors. Which color for adductors may be this orange would be sufficient. These 3 must be more clear. Good. And then the facial spaces. First of all, this is the medial plantar, intermediate lateral plantar bones. Done. No? So we have the outlines of the plantar area. Of course, very important position of the adductor pollicis, 2 heads, so just 1 line. And drawing also in important position 1, 2, 3, 4, 1, 2, 3, 4 tendons of the flexors, long and short. The long has also the lumbricals. No, so I mean that this is not so complicated as we said, but we have to use more structures. Note that plantar aponeurosis is attached to the skin by many fibrous rods. They stabilize the position of the plantar aponeurosis and also subcutis in walking, during walking. So that's why it's very important to know. No, and starting with description. First of all, we see rete venosum, venous network. We said venous network on the dorsum. Then here we have the tendons, maybe just here are the tendons of extensors, both. I'm not separating short from long extensors, just you can add long plus short extensors. Good. Then intertendinous fascia will not be named, but that one is the dorsal fascia, dorsal fascia. This dorsal fascia is in fact also interossal fascia. Here is the plantar interosseous fascia, maybe that's not necessary to mention. Here on the left side, I will color two boxes, one in the same color, the second one also, the orange. We call it interosseous muscles, interosseous muscles, interosseous muscles. Here are four dorsal, which are abductors, and three plantar, which are adductors. The fascia is interosseous fascia. I mean that this is not absolutely necessary. That muscle is adductor hallucis. Here we have the group. Maybe better would be, because we have still place here, we would say that they are compartments, important to say at the beginning, using numerals. D is dorsal, interosseous, plantar medial, plantar central, plantar lateral. So compartments. D is dorsal compartment. They are extensors. Good. Then follows the interosseous, interosseous compartment. They are abductors plus adductors. This is quite clear. Interosseous compartment, interosseous. Then follows plantar, just titled plantar. PM is plantar medial, muscles of the great toe, plantar medial, plantar intermediate or plantar central, and or mid space, also is called mid space, and PL is plantar lateral. Concerning the contents of these spaces, we could say that here we have a moment. This is the tendon of flexor hallucis longus. Fine. So then we are counting also adductor. So in the maybe that we could add just a row saying that this medial space contains the abductor, no, simply three muscles: abductor, adductor, part of this one, adductor, abductor, and flexor pollicis. While this lateral compartment contains two muscles, which is, so two muscles, here are three muscles, which are the abductor, digiti, minimi, and flexor. So there are two. No. And finally, don't forget to place here also the artery with two accompanying veins, which is the dorsal artery, arteria dorsalis pedis, or dorsal artery pedis, arteria dorsalis pedis, dorsalis pedis, plus veins. Then we need also the nerves, superficial nerves. Yes, we have seen them. And then also on the plantar side, there are branches of the medial and lateral plantar arteries with accompanying veins. So we could say that this is the medial plantar artery plus veins. This is lateral, and mid-central or mid-space contains, and then look, I try to draw just 2 lines and another 2. Fine. Concerning the superficial muscles are the tendons of the flexor digitorum brevis, of the flexor digitorum brevis, short flexor brevis muscle. And here we see the tendons of the extensor digitorum longus plus lumbricals. We call the small muscle lumbricals, number 1 to 4, lumbricals 1 to 4, and they are those, right? They are these red ones. So we see the tenderness of the short, of the long flexor in the central position. No, so I mean that it's not bad to see the section, because in the dorsum we still looking at the diagram. This is the dorsum pedis, and in the, you see, dorsum pedis, we already mentioned all the structures. So we have the planta. This would be the last 2 sentences, sole, or we could say either sole or planta pedis. So this would be B, sole or planta pedis. So we simplified description using this diagram, which is very illustrative, also not catastrophically complicated. There is very quickly thick skin, we said, with many tactile ridges, with tactile ridges for sensory innervation, ridges, sensory innervation, then subcutis. We said that this contains this thick layer with these bundles, etc., fibrous with fibers. Then number 3 is the fascia plus plantar aponeurosis. Good. Then number 4 would be the I would say 3 compartments, and we have compartments. We have seen them in the diagrams or also in our compartments. 3 compartments, which is the medial, lateral, and central compartment was mentioned. Number 5, we could say the plantar vessels, plantar artery plus veins. No, medial plantar artery and veins. They run between abductor and flexor, so they are in space PM space. Then artery forms medial usually runs on the side, on medial side. Maybe that would be the drawing here. And before we will complete it, you see the plantar Plantar arteries, there are some variants again. The probably most frequent is that one. We see the arteries, both of them. This is the tibialis posterior tibial artery dividing into lateral medial. Here you see the arch, arcuate artery, and then they run as the plantar metatarsal arteries. Then they supply also interosseous spaces. The fact is that the arteries, the metatarsal arteries, receive the blood mainly from the also from the perforating. So I have mentioned also perforating arteries. Good diagram is that one. Look at the medial and the lateral, then the peripheral ones. We call them because they are plantar, must be plantar. So we call them. They run together. Digital plantar arteries. They are common and they are proper. So on the plantar side are like in the hand. We call them digital palmar and proper. So here are digital plantar and proper. Important is the position of this plantar aponeurosis is the same as the palmar aponeurosis, much stronger with the transverse fasciculi, longitudinal fasciculi. Then again in the distal part, there are small windows through which pass the nerves and arteries. And note please, this is very important diagram showing the muscles, definitely of the medial part, lateral compartment. Here runs the flexor digitum longus with sheath. And note that the tendons run obliquely. So in flexion, the direction of the flexion will be oblique. So as a compensation of this oblique tension, is here the role or the role plays important quadratus plantae, which runs the dorsoventrally or distoproximally from the tuber of calcaneus attached to the lateral margin of this flexor digitum longus. So it compensates the position and tension in the flexion of this muscle. No? And here is the last diagram. We see again the medial plantar, lateral plantar, of course, artery plus veins, and the same medial plantar, lateral plantar, lateral plantar nerve. You see here the arches on both sides. So I mean that medial in the medial palmar compartment, which would be sufficient. So medial plantar arteries plus nerves, of course, this run in the medial plantar compartment, while the lateral, maybe lateral vessels, lateral are found between the quadratus plantae and flexor digitum brevis. So I mean that we could say this is that one. Here is quadratus plantae. So lateral, no, without any comments because you see it. This is the lateral plantar artery plus veins. No, this artery forms an arch, typical deep arch, and floor number 6, floor of the area. Floor is formed by bones, ligaments, and deep interosseal interosseal not, because this is a little bit higher position. First of all, bones, ligaments, important for the support of the plantar arches. So that's why I would like to add in the parenthesis plantar arches, plantar arches. That's it. And the interosseous muscles are situated, located in the spaces between the metatarsals. That's it, metatarsals. So we completed everything. I know it's maybe a bit tiring, not boring, definitely, because anatomy explanation is never boring. It must be understood as the fully exciting. So we are finishing on time. Just last sentence. We completed the review of the topographic regions of the lower extremity. Thank you for your attention. Thank you for your patience, and we can see the drawings in our illustrated, still classical illustrated anatomy, and also the voice in the next week. Thank you. Bye-bye.